completeness and accuracy of the health record. So we need to ensure whatever the documentation health records are provided, it is complete. At the same time, it is accurate. Okay, so based on that, so completeness and accuracy of a health record ensures that all required administrative, administrative, and legal documentations is present, consistent, authenticated, and support coded data for reimbursement, quality reporting, and compliance. So what is the completeness and accuracy of healthcare required for clinical, administrative, and legal documentation and consistent and authentication, support of coded and data for reimbursement, quality reporting, and compliance. At the end of the day, I need to get the proper money, correct money. I should not get a wrong money. So that is what entire this system is going to tell us. What completeness means? Okay, what completeness means? So completeness is nothing. It is a combination of three important things. One is patient and administrative data, then clinical documentation, and authentication. Okay, so these are the compromise. These all three comprise to provide you the information related to the information. Sorry, I came here. Okay, one second. Okay, so completeness. So this it compromises all these informations in the documentation. Okay, a complete health record contains what? Patient and administrative data, clinical documentation, and authentication. What is patient and administrative data? Demography, patient number, patient name, patient date of birth, the service provided date, and the discharge date. Okay, those dates. Okay, date of birth, service provided date, and operating date, and the discharge date, and what is that? Patient consent form, and insurance informations, and the patient ID, MRN ID, visit number, access number, patient name, first name, last name, middle name, surname. Okay, patient address, IP address, and his residential address. Everything compromise and call it as patient and administrative data. That is a demographic data. In clinical documentation, yes, patient history, old records, old progression note, new progression note, and a physician order note, discharge summary, lab test, medical test, any other secondary opinion, consultations, observation documentation. This all together we call it as clinical documentation. Third is like authentication. Definitely we need a signature of the MD or PA, or sometimes the person who operates, who provide the services. Okay, maybe rendering physician, or referring physician, or ordering physician, or interpreting physician, or performing physician, or physician assistant, or practitioner, or resident. Anybody can be. Okay, that need to be there, and their credentials should be there. So they should have the credentials also. So missing discharge summary or unassigned operating note is equal to incomplete record. Missing discharge summary or unassigned operating note is equal to incomplete record. Remember, this makes the completeness. You may end up with the question like this. Okay, so they may ask what are the points required for the completeness, or what are the these three, what is that? These three contains in the healthcare record, what it stands for. The questions may be quite opposite also. Be careful when you're reading the when you're reading the questions. Then accurate. Accurate means what? So accurate means the document should ensure certain points. Okay, that is documents matches the clinical fact. Yes, I cannot assume something. I cannot pretend my own. I cannot manipulate. I need to always go with the documentation matches to the clinical facts. No contradiction between the notes. Okay, progression note is something, discharge summary note. No, it should be same. Diagnosis supported by the clinical indicator. Yes, whatever I'm doing the diagnosis, that should be based on the chief complaint. I cannot take like by saying, okay, I can do leg, I can take egg so that I can get so many money. No, that will not make the accuracy. That will not make accuracy. Procedure clearly documented. Yes, procedures need to be clearly documented. What procedure is performed, and what is the technique is performed for that. What are the devices were used? What are the contrast material, drug material? How many people have approached? On what approach they have done? That much of clarity should be there in the documentation. Correct patient identity on all the documents. That is one more important. Now we have the barcodes, so we need to ensure we are doing the right process. Okay, document acute respiratory failure without ABG, oxygen support and ventilation. It is an accuracy issue. I'm telling some condition, but there is no clinical related clinical features. I have the acute respiratory failure. Doctor is telling patient is having acute respiratory failure. By own, he cannot tell. The patient should have something, clinical indicators like increased ABG, oxygen support or ventilation, something need to be documented, otherwise I cannot consider. Okay, so this is what the accuracy stands for. Then roles of the CCS profession. Okay, so in the CCS exam context, your role includes validating the documentation support for ICD-10, CM and PCS and CPT codes, identifying the documentation gap, ensuring the principal diagnosis selection is supported, applying official coding guidelines, initiating the physician query when needed. Okay, so missing laterality, incomplete. Conflict in the diagnosis. Missing laterality, some of the examples, as per the exam scenario, I've taken this on the recent exams. So if missing laterality means under what it is coming? It is coming under what? Incomplete of the documentation. Conflict diagnosis means inaccurate. What is the issue here? It is inaccurate. No post-operative note. It's also incomplete only. So here, data is not there, it is incomplete. Data is there, but some confusion is there, it is inaccurate. What is available, it is not correct, that is inaccurate. What is not available, that is incomplete. Okay, query need before coding. Query need before coding, accuracy concern. So why I'm questioning before coding means because I cannot provide a proper coding, so I need a accurate report. That is what accuracy concern. Then unclear case and effect, it is documentation gap. Unclear case and effect. So I got operated. After the operation, the complication may come. Just I cannot come with like saying that infection in the knee. I need to tell previously the patient had a procedure in the knee. After 1 or 2 days, the patient is affected with the pus formation. When we examined, we came to know the patient is having the infection. That much of clear documentation should be there. Simply I'm telling there is an infection means there is a documentation gap. Okay, so we need to be little careful. Okay, then next is like in the same we have 4 expert tips for clinical documentation investigation. Clinical documentation investigation. So some of the tips of how the documentation should be there, how the documentation should be followed. Okay, so here why we are included, this means this will ensure this document clear, this clinical document integrity. Why they brought this is a separate entity now. It is a separate specialty they are doing in the inpatient, where before sending the reports for the IPDRG, what is happening? So many reports are getting reverted, denied, incorrect billing, up billing, inaccurate billing. Why it is all happening? Because there is incomplete in the documentation. There is inaccuracy in the documentation. There is no proper documentation is given by the physician. So what I can do, I need to verify the documentation so that I can provide the education to the physician. He will make sure next time the documentations are provided properly. To do that, what control I can do? I can create a team called Clinical Documentation Investigation Team, specialty team, so that they go before going for the coding for IPDRG documentation. They verify everything, whether it is accurate report or complete report. Everything is there. Demographic information is there. Administrative information is there. Clinical information is there. And safeguard informations are there. So everything they will verify. This clinically investigation, the clinical documentation investigation team will do the improvisation of the documentation. That's what the main role. Now this has become one of the biggest specialty. Now there are so many vacancies are going for this. What they mainly do, they do the documentation correction, and whatever the gaps, whatever the inconsistency, whatever the inaccuracy, whatever the whatever the incompleteness is there in the documentation, that will be identified and that will be categorized and that will be shared to the physician, and the same time that will be educated to the physician. That is what the coding documentation, especially clinical documentation investigators are doing. Okay, so 4 tips. Okay, so as a seasoned CDA, we make sure valuable contribution of the professional by keeping the clinical experts at the forefront of the what we do. And the second is like medical necessity, admission status and reimbursement. And third is like our clinical expert ability to professionally communicate with the physician or the skill I help to define our role. And fourth is to always confirm correct impaction based on the changing information with the CMS guideline and update the clinical coding. So why I included these 4 points means what basically CDA people will do. So you may get the questions like this also in the exam. That is what the CCS point are given. Documentation is unclear, query before coding. So when what the main purpose for the CDA person, CDA specialist, he has to make sure if there is no proper documentation, you need to communicate to the physician, you need to query the physician what's supposed to be done. Okay, that is the main purpose of this CDA people. Okay, then key benefits when I do the completeness and accurate supports for correct medical severity, medical severity, diagnosis related grouping, and reduce the claim denials, and PO indicator accuracy and quality measures will be followed properly. That is acts and PSI. Then query process. It's like query must be non-leading, clean and concise, based on the clinical indicator, part of the permanent record. Part of the permanent record. These are what the query process. Okay, so I need to ensure before querying for completeness and accuracy of the report, I should may ensure this 4 point so that the questions will not come back to me, or I will not struggle by asking the incorrect questions. The legal and compliance importance here, accurate and complete records will support the medical necessity, meet high-tech and HIPAA standards, and protects against the loss. Okay, that is OIG, MAC, and RAC laws are there. Then ensures the defensible coding. Okay, so this what is this? This RAC and MAC, I will give you small data on that, and I will provide you high-tech information also, which we'll be discussing in the next domain. Okay, that is what fifth domain will be discussing on high-tech. That time we'll see little more detail about that. Okay, so this is on the legal and compliance importance for the accuracy, so accurate and complete record. Okay, so this is one of the part in the domain. So we need to ensure we are following accuracy as well as the completeness in the documentation. Okay, so that is what stands for